Okay, so we'll make a start as it is 7 p.m. So we have got a full schedule in the webinar this afternoon or this evening. So we'll make a start. So just a good evening to everyone and welcome to our webinar or today's webinar, which is entitled Redefining Survivorship, Supporting People with Treatable but Not Curable Cancers. By way of an introduction, my name is Nicholas Hart and I am your host and facilitator this evening. I'm an associate professor and an NHMRC Emerging Leadership Fellow in Cancer Survivorship over at UTS. I'm also the chair of COSA's Survivorship Executive Committee, who's one of the partners of this webinar, and have a particularly special interest in survivorship care for people with advanced or metastatic cancer. So as a result, I'm obviously very pleased to be here today to facilitate what I think will be a magnificent webinar on such an incredibly important topic and with such an excellent panel. I'd also like to acknowledge the Victorian Government who provided funding for this webinar. It was developed in collaboration with the Australian Cancer Survivorship Centre, the Cancer Councils of Victoria and New South Wales, the Cancer Nurses Society of Australia, and the Clinical Oncology Society of Australia as well. So I'd like to start with an acknowledgement to country. So I acknowledge the Gadigal people of the Eora Nation, upon whose ancestral lands I am coming to you from in hosting this webinar, and pay my respects to their elders, past and present, acknowledging them as the traditional custodians of knowledge for these lands. I'd also like to acknowledge the traditional owners of the various lands of which you're all coming to us from across Australia, and pay my respects to their elders, both past and present, of those lands. I also would like to extend a welcome to any Aboriginal and Torres Strait Islander people with us today in this webinar. So our webinar recognises the expert skills of all health professionals as well as patient advocates who may be on this webinar and the critical role you all play in the management of people affected by cancer. So that is both cancer survivors and caregivers. Our aim is to increase your knowledge and understanding about treatable but not curable cancers. And so hopefully by the end of this session, you will be able to recognise the growing prevalence and common unmet needs for people with treatable but not curable cancers, and also understand how we can screen for these needs, or unmet needs. You'll also be able to understand the need to better quantify the number of people living with this condition, with this stage of disease, I should say, in Australia and around the world, and understand the policy, clinical and research priorities identified for this group. You will also hopefully understand the importance of integrating advanced care planning and palliative care into the management of these people, as well as the development of resources or the identification of resources available to support these people. So this is intending to be an interactive webinar, but by extension, I will finish talking at around about 7:15. We will then go to a live panel for the remainder of the hour, and then open to questions and answers in the next, past 8 p.m. And so we do encourage you to write questions in the Q&A box, which will be moderated or managed by a team behind the scenes, and we will end up asking those questions to the panel during a question and answer section at the end. And so we very much I look forward to your questions and interacting with you at that time. So to start the presentation, it's probably appropriate to define what treatable but not curable cancers actually entails. So thankfully, it is quite a accessible and digestible term, which was very much coined in the United Kingdom, largely through a very consumer-heavy process, which is incredibly appropriate in this manner. And it really is the stage of cancer where it is no longer foreseen that the cancer is able to be cured, but it is able to be treated or managed with active treatment ongoing. This, of course, therefore means that it's quite a heterogeneous group of cancers across both solid tumours as well as hematological malignancies, which therefore presents a range of challenges around how we characterise a lot of this disease as far as it relates to survivorship care. They have different survival lengths, different treatment options. Some can go through indolent disease trajectories, periods of disease stability, periods of disease progression with the potential for further treatment, and also sudden transitions to end-of-life care. And so you can imagine that there's a lot of variety and a lot of diversity within this domain of treatable but not curable cancers. And that's where the benefit of this webinar comes into. The fortunate thing is that survivorship parallels do exist amongst treatable but not curable cancers that have been identified, whether it's people with advanced cancer or metastatic cancer, or whether they're diagnosed at the stage of metastatic disease, or whether they progress to metastatic or advanced disease at a later stage. And so to give you that in a pictorial view or a graphical view, this is the continuum of cancer survivorship. And you can see on the left-hand side where the large emphasis of cancer survivorship research, policy and practice is focused is on people with early stage disease post-treatment for curative intent. On the right-hand side is the transition to end-stage cancer and end-of-life care. But in between those two is this huge chasm of cancers of people living with cancer and their caregivers in the treatable but not curable cancer space. And for the purposes of this webinar, people with advanced or metastatic cancer largely fit within that treatable but not curable space. And that's where we're focusing our efforts on tonight. So to briefly discuss terms is to note that because there'll be several papers referring to advanced or metastatic cancer, advanced cancer is any malignancy that's unlikely to be cured or controlled with treatment, whereas metastatic cancer is where the primary tumor has spread to a distant organ or tissue. So you can have advanced cancers that are not metastatic, such as many hematologic malignancies or central nervous system malignancies. You can have some cancers that are metastatic but not advanced. Very few, I might add, but metastatic testicular cancer is one of those. And then you can have some cancers or many cancers that can be both advanced and metastatic. And the common examples would be prostate or breast cancer. So you can understand it's a very fluid and very complex system that we work within. But of course, we very much value the accessible terminology of treatable but not curable cancer, which will hopefully start taking effect in the literature in due course. But of course, to be able to care for these people, we need to understand how many people with this stage of disease exist in Australia and around the world. And you would be possibly unsurprised to know that we have very crude, very low quality estimates in my mind. So this is a paper that from the UK based on their treatable but not curable definition, which looks at the registry of from 1991 to 2010 of people with intermediate or shorter term survival. You can imagine that you can see that there's a large group of people that deserve to have quality survivorship care that are not yet really taken care of in current systems and practices. And those intermediate to shorter term survival times you see in this graph would most certainly be obsolete for nearly all of them, given the fact we now have the advent of new treatments, better combinations and sequential therapies, and of course the advent of immunotherapy. So 14 years on from there are likely better outcomes. These people are living in the order of years now in many cases, and therefore subsequently should receive quality survivorship care. And that is obviously the intention of which we wish to supply or lobby for, I guess, even in this webinar. And so there have been efforts to try to quantify the number of people living with metastatic disease, which is obviously going to be, in these papers, your solid tumors. But clearly you can see that it doesn't capture the people in the advanced stages of cancer in the hematological space or elsewhere. And so actually the very first paper that I could find was in 2012 from a 2004 dataset in Australia. We've had subsequent estimates in the United Kingdom in the paper I just showed you. And then we have a series of papers from the United States. All of these use the same epidemiological estimation model, which is called MIRMOD, which is a back calculation method that tries to really data mine the incidence prevalence from mortality and survival data in the cancer databases around the world. But this is only as good as the data that it has available to it. There are clear issues of poor timeliness because you can see that if these papers are being published 5 to 10 years after the data is being evaluated, is it already obsolete? There's incomplete data in these data sets, it's imprecise estimates, and it's typically unable to keep pace with new treatments. So of course, we need to develop better systems and practices to capture data in data registries, which we will get to a bit later in this webinar through one of our speakers. And so what are the unmet needs of people with treatable but not curable cancers? Well, we ran I got to lead a systematic scoping review looking at the unmet supportive care needs of people with advanced cancer as well as their caregivers. In this paper, we used advanced cancer definition as treatable but not curable cancer. So it's directly applicable to this webinar. We had 84 studies, 84 papers representing 81 studies. And you can see on the top right-hand corner, we had a good blend of patient-focused unmet needs versus caregiver-focused unmet needs. And you could say that there was well represented across a range of countries, a range of solid tumors, and a range of hematological malignancies. So while this is not characteristic of unmet needs for all of these groups, it is at least indicative to be able to give you an understanding about why survivorship care is so important for these people. And so what we found is probably unsurprising to many of the healthcare professionals, but nevertheless, is that people with advanced cancer living with the disease, the top 5 unmet needs were in the financial domain, the health systems and information domain, psychological domain, physical and daily living domain, and patient and carer support domain. So financial toxicity ranked really highly. I'm sure that's not surprising. The need for patient navigation and care planning, high levels of uncertainty, stress, anxiety, and depression, as well as managing pain and maintaining independence as key aspects. Of course, the caregivers are also very important in this process and equally benefit from having their needs met, which you can see on the right-hand side are a loss of identity and social functioning. I will say number 4 and 5 should be swapped around. I just didn't have the time to correct that before this presentation, but it was a really interesting factor for me to see the relationships and social quite high up in the patient, in the caregiver role that would be worthwhile exploring. So I won't go through this slide, except to say that in the paper, there is a very large table that highlights the subcategories of unmet needs within those domains. And I would just recommend that you go and read that paper to understand that at a deeper level. We won't have time to cover that in this opening monologue. And so we obviously need to reconceptualize or redefine survivorship for these people. And there's been quite a bit of work that's happened since 2019. So if you think it's only been a few years, it's a very new and emerging field of survivorship that we're really trying to establish and deliberate on. And several people on the panel or on this webinar contributed to the development of some of these papers. And the one I'm going to draw your attention to is the one at the bottom right-hand corner by Julia Laikwan, which was published in JCO and really tried to reconsider clinical care policy and research priorities for metastatic cancer in accordance with previous Institute of Medicine reports, which I am going to briefly show you on this slide. Do not have enough time to go through individual factors, of course, but you can read the paper. It's readily available. But it does break down each individual recommendation theme from the Institute of Medicine report in 2006 and the revised report in 2013, and then demonstrated what we wish to apply in the metastatic cancer space. And what I've highlighted in the top right-hand corner is around clinical practice guidelines and definitions of quality, and how can we identify these areas in survivorship care in what I will say is treatable but not curable cancers for the purpose of this webinar. And that's where this work comes in. So 2 weeks ago, 1 week ago, 2 weeks ago, we finally managed to publish some standards and practice recommendations for quality survivorship care for people affected by advanced or metastatic cancer, which includes the cancer survivor and the caregiver in that process. They are the target demographic who may be able to use this document to self-advocate for their care, because these practice recommendations, there's 45 of them, they might be able to use those within their care team to highlight areas of need or areas of want that they might want to have within their quality care. And of course, these standards and practice recommendations are useful for healthcare administrators to be able to try to identify the adequate resourcing needed to be able to support healthcare professionals to be able to provide that care in the first instance. So here you can see that there are 7 standards. Now, on the face of them, it's pretty obvious these 7 standards should be what quality care looks like in any healthcare setting for any disease population. But what we've done is we've contextualized it to advanced or metastatic cancer. We provided a very thorough definition to each standard. And then we've got a series of recommendations with each of those areas, each of those standards. And so your individual healthcare setting might already be doing 1.1 and 1.2, but it might need to look at starting or implementing strategies to improve efforts in 1.3 to 1.6, for example. And that might apply across the entire document. And so this document is a global document. It is translated into 13 other languages or will be translated into 13 other languages, so 14 languages in total. And it's really hopefully going to be a list of criteria that services can do self-evaluations on to identify what they are doing, what they can easily try to do tomorrow, and where they can divert investment and resources to be able to focus for medium and long-term goals in the future. So I won't go through each individual aspect of this, except to highlight that it was a lot of work. I would love for you to read it, and I would love for you to adopt it into practice. But this is open access and readily available online. And so that concludes my 10-minute talk at the beginning of this webinar. So what I'm going to do now is invite the panel members to turn on their screens. And I will start to introduce you to the panel. So as you've seen, we are going to have a panel discussion for the next 45 minutes, and I will just invite each of the panelists to introduce themselves. So Andrea, could you introduce yourself first, please?
Yeah, thanks, Nick. I'm a lived experience researcher at the Daffodil Centre, which is a joint venture between the University of Sydney and Cancer Council New South Wales. And my research focuses on metastatic survivorship.
Thank you, Andrea. And Mel.
Hi everyone. I'm Melanie Lovell. I'm a palliative care physician with Hammond Care in Northern Sydney. I'm a clinical academic at the University of Sydney and chair of the pain node for the Cancer Symptom Trials group based at UTS. Thank you.
Thank you so much. And Megan.
Hi everybody, I am a support nurse for Myeloma Australia, where I facilitate support groups and our support line, as well as a haematology care coordinator at the Mater Cancer Centre in Brisbane.
Thanks so much, Megan. And over to you, Kim.
Hi, I'm Kim Hobbs. I'm an oncology social worker, formerly in gynecological cancer at Westmead Hospital, and tonight representing the Oncology Social Work Australia and New Zealand group.
Magnificent. So as you can see, we have a fantastic and highly qualified and very multidisciplinary panel, which will hopefully be able to provide us with some really excellent insights into survivorship care for this treatable but not curable population. So I'm going to start the first, I guess, sub-theme around lived experience and throw to you, Andrea, as my first question. So as someone who's living with metastatic cancer, can you speak to your lived experience and perhaps reflect on your own unmet needs and your own experiences?
Yes, thanks, Nick. So I've been living with metastatic breast cancer diagnosis for just over 8 years. And as you said, there are more of us in this position now. So it's not just breast, it's obviously prostate, melanoma, lung, colorectal, and of course the blood cancers like myeloma. So we're living for years, sometimes decades. And obviously our experiences are very diverse. And, you know, there are diverse disease trajectories, even within breast cancer, based on your subtype. So my experience differs from what other people's might be. I've been fortunate enough to have long periods of relatively well-controlled disease, interspersed with progression approximately every 1 to 2 years. So I've had periods where I can relax, but you are always waiting for drug resistance to develop and the cancer to progress. And I think what strikes me as being common across the different advanced metastatic cancers is the uncertainty that we are living with. We're on treatment forever. We have to make decisions about balancing work, earning money, how we spend our time with our kids and our family, going traveling, whether we should self-fund treatments in the face of considerable prognostic uncertainty. And we're always sort of trying to look forward. You know, we're hoping for the best, but we're having an eye on what is realistically ahead. So we're in the treatable but not curable space. We are obviously hoping for long periods of time where our cancer is controlled, but inevitably we know it's incurable. So we're trying to deal with that. And in regards to unmet needs, I mean, I think what you highlighted in your review resonates with me, and I think with many people with treatable but not curable cancer. And these needs are quite different from those of people, I think, with curable cancer or who are right at the end of their life. So unique physical, psychosocial and emotional challenges. And I think emotional is one of the key issues. Yeah, so I think that's probably what I would say about my experience.
Yeah, and so were there any sort of unique factors or unique experiences you've had in this position navigating the healthcare system as it relates to your own circumstances?
Yes, and I think what the key point of difference between an early curable cancer and a metastatic or advanced cancer is that often it's a multi-organ disease, and that means we require complex care from multiple different care providers across public and private systems, the hospital and the community. And so one of the major challenges is indeed navigating the health system, and I think you need to have quite a high level of health system knowledge, or else someone who's there to help you to navigate it.
Absolutely. And so could you reflect then, I guess, because one of the things that you sort of mentioned is an inadequate sort of, I guess, workforce or resource to be able to support these people in the healthcare system. And I wondered if you could, one of the things that feeds into that, I guess, is the lack of visibility of these people who are living with advanced cancer in Australia. And I guess even from my own presentation, the inability to accurately quantify the number of people living with this disease in Australia. So I was wondering if you could reflect on the lack of visibility in Australia and whether there is accurate data representing this population to adequately inform policy, practice and service provision.
I think it's a critical point, and I think the word invisible basically is how a lot of us feel, and I think, as you said, this comes back to the lack of cancer data around advanced and metastatic cancer, which literally makes us invisible often to researchers or to healthcare administrators. And as you touched on, the major issue is that our cancer databases don't currently identify people because they don't collect stage at diagnosis or recurrence data. So we cannot get that information from our cancer registries. And so at the moment we're relying, as you mentioned, on modelling or linking health records, which can provide estimates, but it is really unclear how accurate they are. And as you say, they're often dated. I mean, I have done some work with Breast Cancer Network Australia and also with some colleagues at the Daffodil Centre where I work. And we updated, you mentioned Clement's modelling, we updated that to estimate there are 10,500 people living with metastatic breast cancer in Australia. And more recently, I've worked with some other cancer epidemiologists at the University of Sydney with a linked health record data set. And we've got an estimate of 15,000 people living with metastatic breast cancer in Australia. But again, these are estimates, and it's really hard for us to know how accurate they are. I mean, on a positive note, Breast Cancer Network Australia's advocacy in this area has resulted in the federal government committing $1.5 million earlier this year to the Australian Institute of Health and Welfare to create a Cancer Data Alliance, which is specifically to support state and territory cancer registries to routinely collect our stage and recurrence data, which hopefully will help to move this conversation forward and capture that data that is so critically important. And it's not just an Australian problem, it's an international problem. I mean, last month, the Lancet Breast Cancer Commission report called for high quality cancer registry data on relapses to be collected worldwide, and not just to include metastatic breast cancer, but also other metastatic cancers. So it's a widely recognised gap in cancer registries worldwide.
And I mean, we're very blessed to have someone like you who, as a person with lived experience, is also an academic researcher in the field who's really trying to drive change in this area. So I think on behalf of everyone, thank you so much for doing that work, Andrea. It's so welcomed. I'm just going to switch tact now to the hematological malignancy space to you, Megan. And just to see if you could comment, I guess, about the experience of people with hematological malignancies from your perspective, as it relates to unmet needs and their progress through the system.
Yeah, thanks so much for having me join this panel, and a very experienced panel, like you mentioned. And thank you for sharing your experience, Andrea. I learned something from people living with these conditions every day, and I'm grateful for your sharing your knowledge. In the haematology space, I suppose that treatable and incurable condition make up a majority of haematological cancers. So about 60% of haematological cancers fit that mould. And to list those, the most common ones would be multiple myeloma, follicular lymphoma, marginal zone lymphoma, chronic myeloid leukemia, chronic lymphoblastic leukemia. But unfortunately, even those cancers, haematological cancers that could be curable, then can slip into that relapsed and refractory disease, and then move back into the incurable phase. So it's certainly a space in the survivorship world where we have been not quite captured, and I'm really grateful that we can shine a light on that today. My role as a support nurse, both for Myeloma Australia and as a care coordinator, really is to, at that diagnosis point, dispel some of the fear and anxiety, because a lot of the times when people are diagnosed with something like myeloma or CLL, it's something that they've never heard of. When you get diagnosed with a cancer that is quite commonly known, you usually know where you can find more information about that cancer. So that's usually the first point of distress, is I've never heard of this before, is that even a cancer? And then pointing those people to getting the right information about it. The next point would be finding out from that person and their caregivers if their treating team is deciding to treat or not to treat. A lot of times in haematological cancers, they may be in a watch and wait period, which is where they've been given a diagnosis, but they won't be going ahead with treatment, which for some people might be a relief, but for others that can be a real time of distress. And to leave a patient in that zone for possibly months or years without a support framework can cause a lot of distress for patients. Next, then we go into the type of treatment that might be offered to the patient. It can range from intensively infusional and autologous transplant, allogeneic transplant, and wound right down to completely clinic-based blood test and oral therapy. So what we notice in the heme space is a bit of a gap in support for those patients that are more community-based treatment versus the infusional-based treatment, where our day units and our inpatient services are very well resourced in providing support and assessment. So that's a space that we can improve on. Going forward then to past the induction phase of treatment in haematological cancers, patients might shift into a more maintenance-based, and that can be across the board in solid tumours as well. So in that maintenance phase, are we still doing those assessments of making sure that we're not getting further toxicities, where the treatment is not to, the disease may be under control and it's more of a preventative phase, but are we adding onto their toxicity profile when we know that there's going to be more intensive treatment down the track, and how do we capture the differences in those goals of treatment? Finally, I'd like to identify with all of these patients who their healthcare team is while they're going through all these complex treatments. So have they got a good GP that they're connected with? Who is their contact person at the hospital, and how do they problem solve in between those appointments? And that's a really important role where nursing and allied health members become a part of that team and providing that contact with the person. And then finally would be the, as I mentioned, at the relapse phase. So when our haematological patients have come back and the disease has worsened, assessing the cumulative effect of chronic treatment, assessing are we doing good cardiotoxicity surveillance, which is a whole field in itself that we haven't quite got on top of here in Australia, and also have we done an early as possible referral to palliative care. So I think that's probably, there's so much that we can talk about on this, Nick, but those are just some of the broad terms of assessing these patients in that space.
And so in your practice and in your experience, what approaches do you take to, I guess, identify unmet needs in the system in which you work? Like what tools do you use or what methods do you use?
Yeah, and I was really grateful to be invited into this panel, because it was a good reflective practice for me in my in both of my workplaces. And I suppose that I identified that exact topic of those clinic-based community patients, of how are we assessing those patients if we haven't got that formal appointment sitting down in a clinic chair. And where can we address those? And quite possibly we need to expand our MDT spaces where we can identify those relapsed and deteriorating patients, and have a better systemic use for assessment and screening tools at those different touch points. I like the idea of using a disease registry that's more focused on that survivorship space and those surviving patients, where we're capturing those relapsed patients and patients on maintenance therapy. And also it'd be great to encourage more nursing clinical research projects where we're capturing these patients and looking at projects within our cancer centres across Australia that might target those treatable but incurable patients that aren't quite as visible, like Andrea was saying, taking down the cloak of invisibility.
Perfect. And so I'm going to switch tact to you now, Kim. Now that we've heard a lot of the issues and unmet needs from Andrea and Megan in their space, just in your experience and in your professional role, what issues do you commonly encounter when you're engaging with people with treatable but not curable cancer?
So there are many, and we've already heard about a strong theme of uncertainty about the duration of treatment, outcomes, prognosis. But what I found in my practice, and what your research most definitely shows, is that the most pressing immediate concern for patients is around financial support, income security, and future work prospects. So I don't want to underplay the stress and upheaval of an early stage cancer diagnosis, but there is usually more certainty about treatment timelines. Even when they have multiple treatment modalities and treatment may go on for a long time, there's usually an endpoint. So with advanced disease, also as shown in some of your papers, Nick, there are now thankfully more treatment options. There's hope through immunotherapies and clinical trials and precision medicine, but the new treatments come with indefinite timelines, cumulative debilitating side effects, and the ever-present prospect of treatments being abruptly ceased due to disease progression. So bear with me, because patients, their caregivers, and even our health professionals find it really difficult to unravel how we might best financially support our patients. I'm not going to go into a discussion today about the various nuances of public versus private, but that's certainly an issue. But even within a health system that provides universal insurance, so we have a Medicare system that covers most Australian residents, there are still many direct and indirect costs for some services and treatments. And patients with advanced disease are at particular risk of experiencing financial toxicity due to the fact that they have these prolonged and recurrent periods of treatment and episodes of care in what becomes essentially management of a chronic illness. So access to financial support is highly variable. Patients who have financial support from a partner or family, those who have paid leave from employment or income protection insurance, do better than those who are more financially disadvantaged, but those patients are not in the majority, certainly in the public system. There is, however, potential for financial toxicity for all people undergoing treatment for advanced disease. And even those who do have support from family, from savings, from insurance and leave entitlements, those resources are finite and they're frequently exhausted before treatment's completed. So many people optimistically think they will be covered by Centrelink payments, but eligibility for Centrelink support is a minefield in itself. People who have financial support from a partner or who have moderate savings are usually ineligible for Centrelink payments until the support is exhausted. Many people with advanced and the treatable but incurable cancer that we're talking about tonight think they will qualify for a disability support pension. Seems like a reasonable assumption, but this does not apply while people are still undergoing active treatment, unless they are deemed to be terminally ill, the legal definition for which is a prognosis of less than 2 years. And that, I guess, is a sensitive discussion with which oncologists may need to engage if it is the only means of obtaining income support. Generally, however, the disability support pension is only available when the person has completed treatment and their condition is described as stable, and that means that it meets a comprehensive set of Centrelink criteria known as impairment tables. So what we know is that completing treatment with disease classified as stable may never happen for some patients in this treatable but incurable cohort. So this leaves the only option as the woefully inadequate job seeker payment, which has variously been known in the past as unemployment benefit or New Start. Not only is the payment inadequate, but the process to maintain payments is arduous, especially if you're undergoing extensive cancer treatment. You need to regularly submit updated medical certificates to be exempt from seeking work, and that needs to be done every 3 months, although in some cases it can be extended to 12 months for what is known as a serious illness exemption. Most people in this cohort will fit into that. In order to understand what their options are for financial assistance, patients should be speaking with their social worker at the treatment centre. And I think it's just worth finishing this particular section with a brief mention about the NDIS, as many people with advanced cancer believe they will be eligible. The NDIS application and approval process is incredibly complicated, and most people with cancer of any diagnosis will be ineligible, as the cancer diagnosis itself does not fit the definition of a lifelong disability. There are a few exceptions, such as some brain tumours, which may make a patient eligible for NDIS, and the treatment team would normally discuss this if, in their experience, NDIS claims have been successful for particular diagnoses, but it's very uncommon.
Yes, it's a lot of information there, and thank you so much for that, Kim. And so I'm just wondering if following on from that, whether you can comment on the issues encountered by the caregivers as well as the people who are obviously living with cancer as well in this context.
Yeah, so we saw as well from the unmet needs that caregivers have significant unmet needs. They're often the silent partners in supporting patients with advanced disease. Just as there is uncertainty for the patient, the theme of uncertainty is an issue for caregivers. Bear in mind too that caregivers may have additional caring roles and responsibilities in addition to caring for the patient having cancer treatment. They may have responsibility for frail aged parents, for care of children and grandchildren, support for family members with significant mental health concerns, their own concomitant chronic illnesses or mental health issues, and as well as cost of living pressures placing an additional financial burden on them. In my experience, they're usually reticent to speak up about their own stresses. After all, they're not the ones with cancer, and they may think it ungracious to articulate the very real physical, emotional, and financial burden of caring. Getting back to Centrelink, caregivers will only be eligible for Centrelink carer payment or carer allowance when the patient requires a significant amount of hands-on care in completing basic activities of daily living, such as mobilising, personal care, transport to appointments, feeding, and so on. Carers of terminally ill patients may qualify for carer payment, but where the definition of terminal illness in a legal sense is prognosis less than 2 years, Centrelink adopts a definition of a prognosis less than 3 months. So it may be at very end of life that carers become eligible for payment. Even then, they'll be required to be in attendance for a significant period of time, and those payments are reviewed. And parents of children with advanced cancer face similar obstacles. Even though they're required to be in attendance as guardians for their child's treatment, they may not qualify for carer payment, and they'll otherwise also be limited to job seeker payment. And with that comes conditions for submitting documentation to seek exemption from looking for work. All caregivers need to be linked to the services that may be able to alleviate some of their burden, but they're usually unaware of where to look. We've got some resources in the attached to this webinar, and people will have access to those, but it really is a bit of a minefield for both patients and caregivers. Thanks
so much, Kim. I'm going to switch across to you, Melanie, and the palliative care perspective. And I was wondering if you could explain what issues you encounter in the palliative care space for people with treatable but not curable cancer.
Thanks so much, Nick, and it's lovely to be with you on the panel, and lovely to hear from Andrea, Megan and Kim. And we face similar issues. There's a strong theme of uncertainty, which Andrea described so beautifully. You know, how does one, you know, live as fully as possible, you know, keeping in mind that things could change. Often the people we're caring for face multiple losses, unable to work, unable to fulfill roles in their family life, not being reliable as friends as they've always been. And so people often need to find a new way, a new normal, if you like, of how to live and live meaningfully and purposefully. And often there's not in the busy cancer centre space an opportunity to do that. And so one of the things that Hammond Care's doing to seek to address this is providing facilitated 6-week group programs called Embrace for people can gather who are in similar circumstances and have space to engage with these issues and each other and reflect and be empowered to explore new possibilities and priorities. And we're developing a similar one for caregivers. Others have mentioned the high symptom burdens, and thank you so much for your presentation there, Nick, on the unmet needs. And absolutely, that's often the trigger for referral to palliative care. Fatigue is a massive problem, pain, anxiety, depression, breathlessness, appetite loss. Nick, you were asking about tools that we might use to screen for these things, and for everyone who comes and sees palliative care across the country, they're screened with a symptom assessment scale which looks at how bothersome or distressing a particular symptom is for people, and that gives us a way of prioritising what's most urgent to be addressed. We also look at mobility, function, psychological and spiritual distress and caregiver needs, and can make appropriate referrals. I think one of the issues we often face is late referrals. I think we often do meet people quite late, and we do understand that introducing palliative care is a difficult conversation, but it is often people come to us and say, oh, if only I'd known earlier what you offer. And the palliative care doesn't exclude other treatments. It's often delivered alongside disease-directed therapies. And can be stopped and started as needs arise and are met.
Perfect. And so often when we discuss uncertainty, because that is a very key theme that seems to be coming across, there's often, I guess, a concept of what people would say is walking two roads. And I was wondering if you could reflect on that, I guess, in your practice and how it applies.
Yeah, thank you, Nick. That's a phrase that comes from a podcast called The Waiting Room Revolution, run by Dr. Sen Xiao and Sammy Winemaker, and it's I highly recommend it for people living with treatable but incurable cancers. And it's walking two roads is really about empowering people to take control of their circumstances by preparing for different outcomes. So planning for the worst case scenario means that planning is dealt with, it can be parked, and allows people the freedom to focus on living well now and, you know, hoping for the best, as Andrea mentioned. The other things that the podcast mentions is the 7 keys for unlocking a better illness experience. And one of them is addressing the ripple effects, is the phrase that they have found through a consumer process, you know, is the phrase that most resonates. And that's the concerns of family and friends about how to, you know, how people can support their family and friends to support them.
Perfect. And so I'm going to switch tacks now to sort of try to conceptualize what we might all view ideal care to be in this sort of setting. And so, Andrea, I was wondering if you could, in your experience, describe what you feel ideal care would look like, and I guess comment on your perceptions of gaps in the care that you've received.
So, I mean, obviously the obvious response is exactly what that's been reported in the ASCO and MASC standards, you know, coordinated, patient-centered, evidence-based, accessible and equitable. But what does that actually mean? And to me, it's about flexible care that is tailored to the point in your disease trajectory. I mean, in my experience, and I know from speaking to a lot of other people, you need more intensive support when you're first diagnosed, obviously, but obviously during periods of disease progression or changes in treatment, and then again towards the pointy end when you start running out of treatment options. So I think that flexibility is really important, so that you can have more access to, you know, cancer navigators or your cancer nurse or psychologists and everything when you need it. And in terms of gaps in care, I mean, I think unfortunately our cancer systems and many of the survivorship services are still designed for dealing with people who are being treated with curative intent, who are post-treatment. And in fact, I've had experienced instances where I've actually been told I'm ineligible to access those services because I'm not post-treatment. I think things are changing, but I mean, I think it's really important that care provides us with opportunities to access exercise programs, appropriate psychosocial care. I mean, for me, I think some of the gaps in care have been filled by my metastatic breast care nurse. And I know in the breast cancer area, we're very lucky to have a high number of nurses. But when I was first diagnosed, and I was diagnosed de novo metastatic, I'd never had an early breast cancer diagnosis. I did not have access to a breast care nurse, even though there were 4 at my hospital. Unfortunately, after about 6 months, a metastatic breast care nurse was appointed, and she was, you know, really important in addressing those gaps, and linking me up to services within the hospital and within the community. So I would, you know, advocate for a cancer navigator or a cancer nurse, I think, to help address some of those gaps.
And do you have any reflections on the role of the GP in your care and how they might fit, I guess, in this model?
So I suppose that I'm very lucky. I have had the same GP for many years, and my GP has been really important. And I think that's my advice when I speak to people who are relatively newly diagnosed with a metastatic diagnosis, is make sure you have a good GP, and if you don't, find one. Given the longevity of the diagnosis, I think it's really important to stay in contact with your GP, and not to forget about them. They're a really important part of your care team. I use mine as a resource and a sounding board, and they provide, you know, great emotional support. And I think from a practical perspective, they give me access to allied healthcare professionals through the GP management plan.
Perfect. And so in your perspective, Megan, as it relates to the hematological space, what do you sort of, I guess, reflect on as what ideal care might look like for people with hematological malignancies?
Yeah, well, I suppose I really echo what Andrea mentioned, and there is a lot of overlap there, and that conduit between your healthcare treating team and the community healthcare treating team really needs to be solidified when you get a diagnosis with one of these conditions. So really making sure that you have if you haven't regularly seen a GP, you're going to have to start doing that now. And that's going to have to be part of your regular routine. I would include in that having a good connection with your community pharmacist as well. Unfortunately, this comes with a lot of medications, whether it be supportive medications or treatment medications, and preventing errors in that space from what you've been prescribed and what you need out in the community, and also preventing polypharmacy where possible. So having a clear communication between all of those healthcare providers and that one contact person at your hospital that you can help navigate. And I think that's been echoed as well, having that connection, that person with experience, whether it be a care coordinator or a nurse navigator, or even in rural settings, that might be a really good nurse, receptionist in the GP practice. But whatever that person is for you, that's going to connect you and help you solve those problems of navigating the healthcare system. I think that's important.
And that sort of really comes through in that unmet needs work earlier on about the patient navigation for the caregiver as well as the person living with cancer. So that's really excellent reflections there. And so to you, Kim, I'm going to ask the same question from your social worker perspective, what you view ideal care is.
So as social workers, after we've dealt with the pressing problem of income support, often the next question is, what community support services can I access to maintain independent functioning and good quality of life in the community? So psychological and practical support services. And unfortunately, now we're going to continue with the theme of uncertainty because there is no straightforward answer. There are huge variations across state jurisdictions, and even within treatment centres, there are differences across tumour streams, as some diagnostic subtypes are eligible for specific services that are specific to their diagnosis and not to other patients. But speaking very generally, the first port of call for support are cancer-specific charitable organisations and NGOs, the state and territory cancer councils, travel and accommodation schemes for regional patients, and support for First Nations people through Closing the Gap initiatives. Peer support, whether that's one-on-one or in a support group, may be an invaluable resource for some, but availability is patchy at best. Again, most patients and caregivers won't be aware of the various services to which they have access. They need to be directed to service providers. That's the responsibility for all of us in the cancer care team, but it does fall primarily to social workers, care coordinators, navigators, CNCs, and so on, and to cancer councils. And that number is 13, 11, 20, in case you need reminding. I think that all patients over 65 or 50 for First Nations people should be encouraged to request an aged care assessment through My Aged Care, as this may open access to services such as domestic assistance, personal care, transport, and respite care. However, of course, there are limitations, costs, and waiting lists to contend with. So it's not a fix-all, but I think that if they get that assessment ball rolling, that will be an advantage. There are, of course, additional challenges for people living outside the major cities and metropolitan areas. And so their needs for treatment support are exacerbated and magnified by their geographic isolation. Certainly, there's a great improvement with establishment of regional cancer centres to provide adjuvant treatments and access to clinical trials and teletrials, but so those in very remote locations still have a distance problem, particularly those who benefit from the access to hands-on in-person services in their local communities. That's really difficult to manage. In terms of access to care, to psychosocial care, ironically, the COVID pandemic has done us some favours, as we now have the option of using more sophisticated and stable virtual platforms for telehealth consultations, as well as providing access to psychosocial support. But if we're talking ideal care, there is nothing better than a face-to-face individualised psychosocial assessment to assist in directing patients and caregivers to the supports and services that are best suited to them. The problem is a workforce one. Psycho-oncology teams are under-resourced, even in most tertiary cancer centres, and usually non-existent outside the big centres. There are variations according to location, cancer site, socioeconomic status, with most people who have limited financial means not being able to afford out-of-pocket charges for private services. And of course, our priority populations, the LGBTQIA+, First Nations, culturally and linguistically diverse, are even more marginalised when it comes to accessing tailored and specific supports that resonate with their circumstances and culture. And we need to understand that the cancer diagnosis doesn't happen in a vacuum. So the patients and their carers are frequently dealing with other pre-morbid chronic physical or mental health problems, or a pre-existing financial burden. The cancer team needs to work in harmony with other health and welfare service organisations to ensure that the care is both optimal and seamless.
Perfect. And so I'm going to switch to you, Melanie. And I would love to get your reflections on palliative care, the scope of palliative care practice, and I guess the ideal scenario for palliative care in this space.
Thank you, Nick. Yes, the nice thing about palliative care, it can be provided where the person prefers it to be provided. So in the acute hospital, in a palliative care unit, or at home. Before I go too far on that, I just wanted to come back to Megan's point about community pharmacy and how important they are. And we often see people who've been discharged from hospital, they have a few days supply of medication, but the communication about exactly what they are and what they're for and so on may not be optimal. And the other thing we're facing at the moment is some shortages of medications, particularly opioid medications. And if people are struggling with that, there is some helpful information on the TGA website, but nothing replaces a conversation with the community pharmacist to say, this is what we need. Can you please get it available? So in terms of ideal palliative care, early referral makes a really big difference. And there's some lovely work that's been led by Professor Jenny Phillip looking, it's called Care Plus, which there's a link in the resources, and talks about what the palliative care team does as opposed to focusing on the name of palliative care. People who do see palliative care will have a full screen of their needs, their physical, psychological, social and spiritual needs, and an assessment of their care giver. Then they'll have those needs addressed, including with self-management strategies, and palliative care will provide information and support and conversations about goals of care. That's sometimes known as advanced care planning. Palliative care often has social workers, occupational therapists, physiotherapists, pastoral care volunteers, medical and regular nursing input. I guess the next thing is talking a little bit more about advanced care planning, which empowers people to express what their wishes are, what their values are, what their care preferences would be in different circumstances. It's a conversation that changes over time as people become, people's circumstances change. And if the balance of treatment between burden and benefit has shifted, then, it's important people know that they can make choices. They don't have to go down a certain route. They can choose no longer to go into acute hospital. They can receive care at home or in a palliative care subacute setting. For people who are referred early and have those conversations, have their needs met, they might then have 3 contacts with palliative care during that referral, and then come back months or years later if needs arise again. So it doesn't mean that palliative care is involved all the way through the treatment.
I think it's very helpful. I think it's very helpful as well, because I think a lot of people who have never had to interact with palliative care before might have some stigma associated with it. So I think it's a very helpful explanation to allow people to conceptualize how palliative care fits in with the overall care of through their journey of treatable but not curable cancers. So I'm going to switch to, I guess, the community you mentioned outside of hospital. So to Andrea, I guess with regards to metastatic cancers, in your experience, what supports might be available for people in the community?
Well, I think like Kim mentioned, I think there are, the key organisations like the cancer councils. I mean, they can provide, masses of information and also services. And I think it's really important to look for your tumour-specific organisations in terms of advocacy and information and support. And we're very fortunate in the breast cancer space that we have a national organisation, Breast Cancer Network Australia, and also smaller, more specialised breast cancer organisations. So Brave, which focuses on young people, and Pink Hope, hereditary cancer. So I think it's about finding out what organisation there is for your specific type of metastatic or advanced cancer. I think it's really important to be connected to appropriate allied health professionals in the community, which to me means finding, like a physiotherapist who has expertise in oncology and is prepared and understands what it's like to treat someone with a metastatic or advanced diagnosis who might have bone metastases, exercise physiologists who really understand, again, what a metastatic diagnosis is, and even psychologists, oncopsychologists who really understand the difference between an early cancer diagnosis and a metastatic or advanced diagnosis. For me, I've been very fortunate to have access to a metastatic specific support group, and I think it's invaluable being able to connect to others with lived experience, whether that's in the community or through your hospital. But I think it is actually very challenging sometimes to make that happen. And I'm very aware that I think the 2 cancers that do have access to stage-specific support groups are breast cancer and multiple myeloma. I think, Megan, you might be able to confirm that, but I think they're from my research and understanding that there aren't a lot in some of the other cancers, and I think that's really important to connect to people with a similar diagnosis.
It was a very beautiful segue that really assisted me, Andrea. So I'm actually going to throw to you, Megan, to see if if you could comment on the supports available in the community in the hematological space.
Yeah, thank you. So I am biased, but I am very proud to work for Myeloma Australia, where all of our each state has nurses based, particularly for local support for people living with myeloma. We offer a 1-800 myeloma support line that's available Monday to Friday. We have peer support available in face-to-face groups as well as online groups for specialised myeloma cohorts, including younger people living with myeloma, carers and loved ones looking after people with myeloma, and people with smouldering myeloma, which is a kind of pre-myeloma phase. There are two other really great major organisations in the haematological space. That includes Lymphoma Australia, which has a similar nurse support model, and then the Leukemia Foundation, which I think most people have heard of, which provide amazing support more in those practical realms of accommodation, transport, some fiscal support, as well as their newly launched app, which you can find out on the website, which is a digital energy coach. Concept of having patients being able to monitor their fatigue living with treatable and incurable cancers, which is, as we know, and across the range of cancers, is one of the most debilitating symptoms of living with chronic disease and chronic cancer.
Perfect. And so I'm going to switch tacks now in the interest of time to research and research priorities. And Andrea, you wrote a wonderful editorial that I had the luxury of being involved in around ideas around research priorities to improve outcomes for people with treatable but not curable cancer. And I just we wanted to know what your reflections are and what the research priorities are that you would like to see.
Well, for me, I think the fundamental research priority is to actually have research done on people with metastatic and advanced cancer in the survivorship space, because currently we are often excluded from survivorship studies because we're not post-treatment, and also because we're not readily identifiable because we're not listed in the cancer registry, so that makes recruitment difficult. I mean, I think fundamentally, if we're not included in the survivorship research, then you cannot develop survivorship interventions that are designed for our specific, physical and psychosocial needs. So I think that's one of the key research priorities. And I think there's also an urgent need to understand how we can adapt existing survivorship interventions. So, for example, fear of cancer recurrence, how that can be adapted for fear of progression, or exercise interventions for people who have metastatic or advanced cancer, in particular, things if you've got bony metastases. So I think that those to me are some of the key priorities.
Thank you. And I just to note at the moment that there will be a Delphi study circulating soon, which I will distribute to the registrants of this webinar as well, which is actually going to try to be an international set of research prioritization for people with advanced or metastatic cancer through the Multinational Association for Supportive Care in Cancer, a bit wordy. So that will certainly come out soon. So Mel, I would love to get your perspective from the palliative care perspective around the research priorities for this population through your lens as well, please.
Thanks so much, and great to hear about that upcoming process through the Multinational Association. Our Cancer Symptom Trials Group in Australia conducted a Delphi study with consumers and healthcare professionals to identify the most important symptoms in terms of frequency and impact, the need for interventions and service delivery models, and further research priorities. The symptoms that came up as being the highest priority were fatigue, constipation and diarrhea, which was really interesting. And the other one was urinary symptoms. And our current tools don't even screen for urinary symptoms. So that's been very interesting. Research into psychological therapies for cancer symptoms was seen as a priority for health professionals and consumers. I think one of the gaps that we see is how to manage chronic pain in people with cancer-related pain that goes on for many years. And we know that about a third of people with treatable but not curable cancers have have pain. We've got reasonable evidence how to manage acute pain and pain at the end of life, but as we've discovered in chronic pain, opioids may not be the best option, and in fact can cause harm for chronic pain, for chronic cancer-related pain. So there's quite a few questions there that we haven't quite got the evidence to answer yet.
Which is the fun job of research, is that we'll be able to search for all of those things, I hope. So I'm going to switch to advocacy. I'm going to quickly check back in with you, Andrea, around, you've mentioned your work with Breast Cancer Network Australia and their advocacy, focusing on quantifying the number of people with advanced or metastatic cancer. I was just wondering if you had awareness of other advocacy efforts.
Yes, so I mean, Breast Cancer Network Australia has got a lot of advocacy initiatives in this area, and actually most of them are relevant to people with not just breast cancer, but other forms of advanced or metastatic cancer. I mean, one of the things that they're focusing on is faster and more equitable access to treatments. So a drug that works in one cancer may work in another cancer that has a similar biological pathway, but drugs are currently typically approved for a particular cancer rather than a particular pathway. So they're not approved on the PBS and not available unless you self-fund. And Australia's approval process for actually getting drugs listed on the PBS is onerous and long. I think the average time for it that it takes from TGA registration for oncology drugs to PBS listing is 442 days. And many of us just do not have that amount of time to wait for drugs to be listed. And I think there's also, the key question around visibility and understanding of this population. So I think there's actually education for healthcare professionals, cancer not-for-profits, about exactly who we are and what our needs are. I mean, for example, the Australian Cancer Plan, we're not identified as priority population. And so I think work and advocacy needs to be done to help us make us more visible for funders, researchers, and the not-for-profits. And I think finally, one of the things that BCNA is doing might seem quite small, but it's about using inclusive language. For example, the use of the term survivor. A lot of us don't identify with that. I mean, I would say I'm currently surviving, but I'm not, and I never will be a cancer survivor. So little things like that can actually have a big impact.
I agree. Language is such an important focus for this area, so I really appreciate that reflection. And so Kim, in your experiences, you've obviously had some experience with financial toxicity. I would love to hear your insights into important areas of advocacy in this space.
I think we've said a couple of times that the tumour-specific support organisations are a great way they can advocate to articulate the concerns of the people with lived experience in their groups. But I think at a bigger policy and advocacy level, COSA, Cancer Councils and Cancer Australia can advocate to government on important issues. And there are a couple of recent examples to highlight. And one is, as you said, both the financial toxicity and financial consent work that we've undertaken. The links to those documents are also in our resource list. So there's an informed financial consent document and a financial toxicity roadmap, which is the work of a subgroup of the survivorship, COSA survivorship group. The Centrelink system is unwieldy and unworkable for many people. And so over a couple of different times, Cancer Council Australia and AUSWANS have partnered to make submissions and to speak with a parliamentary Senate inquiry advocating for changes to the disability support pension and to JobSeeker. We've not seen the outcome of those changes yet, but we won't give up. And I think it's really important for professional groups and cancer-specific groups to partner together and advocate on the things that we know and there's evidence to say are important for the people with whom we're working.
And Megan, I'm sure advocacy is a core business of Myeloma Australia. I'd really be interested in your perspectives around what advocacy efforts are happening in your space.
Yeah, that's one of the pillars of our organisation is advocacy for our members. So as Kim and Andrea mentioned, that one of our biggest advocacy roles we do is try to push the PBS for allowing new treatments and new medications, as much as we are still in the near future in the incurable space. We would very much like to move into the curable space. So we're constantly advocating for some of the exciting treatments that are available overseas to be funded here in Australia. We've recently launched a new program based on some grants that we've received called the NurseLink program, and that's basically us able to teach other nurses in more rural and remote settings about myeloma and how they can advocate for their patients locally, rather than just in the tertiary space. And finally, we advocate for support organisations to be a more formal part of the healthcare team, and therefore we need government support to do that, which we currently don't have at Myeloma Australia.
So that concludes the panel session. I'm going to open it up as a Q&A, and we have quite a number of questions. So I'm probably going to start from the top, and there's actually a couple of a question that would be useful for you, Melanie, as well as you, Megan. I'd love to get both of your thoughts on this. One of the attendees has asked the question of, within the non-curable space of diagnosis, what is the panelist's view of a person's request for a second opinion? Is it met with empathy and support or otherwise? And so Melanie, I'd go to you first.
Thanks, Nick. I think we're always supportive of people wanting a second opinion. We want people to get the best evidence-based treatment. And so, yeah, always welcome.
And Megan, what's your experience?
Yeah, and it's something that comes up on our support line quite a lot. And I like to kind of turn that phrase around more to that you're seeking a supportive opinion. Your healthcare provider, when you're in an incurable disease, becomes like a very long-term relationship. And I said, if you're in this marriage with this person and there might be some communication misalignment, it's not disrespectful to get a supportive opinion and see with that to make sure that relationship's going to work long term.
And I suspect with a lot of the uncertainty in this space, it certainly can't hurt to have more information in this area.
Absolutely.
So there is a question for you, Kim, which is that not all people living with metastatic cancer are old enough for aged care, and you've clearly identified the problems of being covered by NDIS. So for people of working age, how do you provide the support needed, and how can we advocate for better government services for this group?
It's a terrible problem. People who are aged under 65 or 50 for First Nations people really are at the mercy of imposing or getting support from family and friends or paying privately. There just are not services, except if they belong to those certain tumour streams where there's a support organisation. Cancer Council can provide some limited financial assistance to pay for some private services, and certainly the organisations like Leukemia Foundation and so on, Rare Cancers Australia, and many people in this group cohort will come under the umbrella of Rare Cancers. But there are no services for people who do not have a permanent disability, and that's most people with cancer, because they're still being treated. So I'm sorry, but I don't have an answer to that, except to call in all the favours you have from friends and family, and to if people are saying what can they do, well maybe they can help out with housework and transport and things like that you can't get from a government service if you're not aged or permanently disabled.
Thanks, Kim. And so there's a question for you, Mel, which I'm going to merge. I'm going to add a bit onto their question so it'll be a double question. So the question is, should advanced care planning be a component for people living with treatable but not curable cancer? And I know you touched on this earlier. It could be a tool to have insight into people's values and preferences for treatment. And of course, I suspect that, a good advanced care plan or advanced care directive is important, but also to have medical treatment decision maker appointed as well. So I was wondering if you could reflect on that general information.
Yes, thank you. It's a great question. And I think one of the things that came in one of the papers you presented there, Nick, was the sudden, there may be sudden transitions to end-of-life care. And sometimes things happen that not only affect the care for people, but also their capacity to make their own decision. And that's where the importance of a substitute decision maker. It's called a different thing in different states. Enduring guardian is what it's called in New South Wales. And so we want everybody to have a voice, whether or not they have capacity to give voice at a certain point in time. So if in advance they've shared what's important to them in different circumstances, then that is recorded. We just recently did some work with Cancer Australia in the pancreatic cancer space and had the opportunity to do a lot of consultation with Aboriginal and Torres Strait Islanders. And the phrase that they used was, it's an opportunity for self-determination. So they could express what they would want in different circumstances. The advanced care plan is the ongoing conversation, and an advanced directive is a legal document. And again, the requirements in each state are a little bit different. But thank you for the question.
And is there a stigma around people accessing or wishing to even discuss an advanced care plan? Is it something that makes them face reality a little bit with what they're going through? Or is it quite I don't want to say comfortable conversation, but a conversation that isn't so loaded, I guess?
Yeah, and it doesn't have to be loaded. I think often people get very anxious about it and start with, would you be for CPR? Would you be for intensive care? It doesn't need to be that way. You can start to talk about, it's really important for us to know what's important to you in different circumstances and to understand what your care preferences are, and start to talk about goals of care. And often people in a consultation, when you're doing a comprehensive assessment, there'll be cues that people will talk about what's important to them and who's important to them and who would be making decisions. So it is tricky, but it's important. And I think once the conversation starts, people are really grateful to be able to express what's important to them.
Fantastic. So there's a question that's probably for me, and I'm going to throw you in there as well, Andrea. And it's to do with how do we feel we can incorporate the standards and practice recommendations into clinical practice? What needs to happen to make this a reality? And I'm really grateful for the question, because I really had to rush talking about it in the presentation, but I still won't labour on it now. The way I explained it to someone who asked this question just in conversation recently was, I would like to see individual cancer services use this document to self-assess and self-evaluate. What are they doing now? On that list, what are they actually doing well? But there are certainly going to be things. That's 45 recommendations. I'd be stunned if they were doing them all. What would be the low-hanging fruit, i.e. what are the items in that recommendations that we feel we could implement tomorrow? And what are the other ones that we're going to need to try to advocate for, determine investment for, allocate resources for? Because one of the overarching feedback we got from around the world, because if you remember, this was developed for low and middle income countries, not just the wealthy countries, was we're never going to be able to do all of this. And my answer to that is that's completely okay. What we're trying to do is say, what do we feel is best practice survivorship or supportive care for these people? And if they can do a self-evaluation of where are they now and what can they do quickly, and maybe what will take a little bit more planning time, advocacy, and hopefully some political will for investment, is where I would like to go with it. From a research perspective, we need to do a lot of implementation work. But from the service level, real world scenario, that's how I would like to see it used. Andrea, do you have any reflections, I guess, on the work?
I agree with you, Nick. I think fundamentally what is so important is that we now have a list of what those standards are, so that people, as you say, can refer to them, and it would be impossible to implement them all. But I think from a consumer patient perspective, it gives us a great list of things that we can sort of then focus on and say, these are the standards, and then advocate either at your hospital level or through your cancer not-for-profit organizations to sort of highlight where the gaps are. I think a lot of change will be driven by patients identifying that things that are not available where they're being treated, and agitating for change to happen. And I think it comes down to often, unless we measure things are never going to change. So I hope that would be part of how we'd actually drive these standards into being part of how we deliver care.
And that's my hope too, is that people who are living with the cancer or their caregivers feel at least a sense of empowerment, that they actually have something where they can hopefully self-advocate. Not that the responsibility should be on them to self-advocate, but it at least allows that opportunity as well. So I have another question. It's for the panel in general, so I might go around the panel. We haven't said so much about education on this topic for healthcare professionals as much. I mean, of course, this webinar is a form of education. Suspect a lot of general practices or GPs don't know much about the growing number of and needs of people with treatable but not curable cancer, and possibly many other healthcare professional groups. And so I just wanted a reflection on that, and I guess education for healthcare professionals in this environment. So Mel, would you like to start from the palliative care perspective?
Yeah, it's a great question, and relates, I think, to the previous question as well in the Q&A there about scalability. And the key, I think, is going to be that those with the highest needs get the most specialist services, and those who have less severe needs, less severe distress, less severe symptoms can be managed in palliative care setting by primary palliative care. So for instance, our current model is that we have a lot of our, we have a nurse-led service, we have a range of training of the nurses, and those who have, the patients who have higher needs get referred up to nurse practitioners and then to the doctors, and referred to the rest of the team. So it's a huge issue, as there's an increasing number of people in this category, to make sure that there's equitable service. One of the possibilities that we've looked at, there's a range of digital solutions actually, and telehealth is an important one, but also patient portals where people can access support. Electronic collection of patient-reported outcome measures is another important one, so that patients can prompt, when they've got levels of need, and get access to services.
I love that. And Megan, from your perspective, from the nursing perspective, where do you see, I guess, Myeloma Australia is one example, as an opportunity to provide education to health professionals in this space, recognizing that I think one of the barriers or challenges that I constantly hear, and it's a fair challenge, is time availability to participate in educational products.
So part of my role at Myeloma Australia is also to provide healthcare professional education to both nursing, allied health, and GPs where possible. So we do provide seminars, and I do reassure my patients that myeloma relatively still is quite rare, but unfortunately is the most expensive cancer to treat out of all cancers because of the continuum of care that's required. So I do reassure patients that although their GP may have not treated someone with myeloma before, that's the role of their specialist, is to keep an eye on the myeloma. But what we're really wanting from the GP is to keep an eye on everything else, and to be navigating to those, like Andrea mentioned, there's a multidisciplinary, multi-specialist usually requirement, and comorbidities involved with having a chronic cancer. So healthcare professional education certainly we need to keep on working on that space, and working on GP education to make sure that conduit stays open. But the role of the GP really still, we're not asking them to be specialist cancer providers, but more to that connection and communication stays open.
And thank you so much, Megan. And so there's a final question before there might be another final question from me, is from the floor, which is, with both the increasing numbers and people living longer with treatable but not curable cancers, it goes to scalability, and what you mentioned as well, Melanie. We won't have enough specialist nurses, palliative care teams, and NGO supports. How will we scale these supports? Because it is true, we are in a resource limited setting. And how can we scale these supports and make sure that those with lower health literacy or from priority groups don't miss out? And so, Kim, I might throw to you first if you're happy to have a go.
Yeah, so the problem we have is that not only do the patients and caregivers not know what they don't know, but neither do we. And so the way that we're going to find out is to be educated by our patients and carers. So we're going to all have to ask the tough questions and not be frightened about that. Let's find out what's happening for that patient and family when they're not sitting in your hospital bed or your clinic chair or your treatment centre. What is it that's happening for them? And it's not just about the cancer diagnosis. And that's why I think particularly people from priority populations and from a lower socioeconomic group, or people who have comorbid health conditions with their cancer, we need to partner with the services that are already providing help for them. We need to provide seamless care, but it's also a way of stretching the resources. And so if they're already engaged with an aged care service, or some of them will be engaged with disability services, then we can leverage off that, and we can partner with them for better advocacy. And I think that's what we as oncology social workers have prioritised, is to work with our stakeholder colleagues to bring up what's important from patients' point of view. But we start to do that by asking them the questions. What's happening for you? And that takes a little bit of time, but it can direct where you then target your care.
Thank you, Kim. And so I have one final question for each of you. I will limit you to 30 seconds each, just in the interest of time. Is if you could change one thing tomorrow, or if there was something pressing tomorrow that you could change in your context for people with treatable but not curable cancers, what would that be? And I'll start with you, Andrea.
Well, my answer is probably quite obvious. It's around collecting the data at the cancer registries, because I think that is fundamental to highlighting the size of the population and then allowing good research to be done on this population.
Thank you. And Megan, what about you?
I would wish for people across all across Australia that's been diagnosed or living with a incurable cancer, that they have access to one specialist support person that can be a connector between their healthcare team. So private, public, rural, tertiary, everyone needs access to somebody to help them navigate the healthcare system.
Perfect answer. Thanks, Megan. And Kim, what about you from your perspective?
So not achievable at all, but they would have at least one opportunity for a face-to-face psychosocial assessment to get a real sense of what the needs and supports are before they reach crisis point, before they fall off the cliff, before they abandon treatment for reasons that we could have ameliorated had we known about them.
Thank you, Kim. And Melanie, lucky last.
I would like all people for whom it would be appropriate and suitable to receive an early referral to palliative care.
Perfect. Thank you. And so before this webinar comes to a close for the people in attendance, first of all, thank you for attending today's webinar. I'd just like to share a couple of things first. So we would appreciate it if you would complete a 5-minute webinar feedback survey telling us how wonderful we all were, which will be posted in the chat section, I believe. Here it is, right on cue, Liam. Thank you very much. And you'll also be prompted to complete this survey when the webinar concludes. And so this will allow for future events to continue to be improved and to be tailored to your needs. So if you miss it tonight, a post-event email will also be sent out tomorrow, including the webinar feedback survey link, as well as a resource list, which has been referred to by Kim and several others throughout this conversation, which will include further reading and resources for health professionals, as well as resources to provide people surviving cancer and carers to support their care needs. And I hope you appreciate my change of wording there, Andrea. So finally, we would also like to thank the collaborators of the Australian Cancer Survivorship Centre, Cancer Councils Victoria and New South Wales, Cancer Nurses Society of Australia and Clinical Oncology Society of Australia. And I personally would love to thank this magnificent panel. You've been absolutely wonderful. And so thank you, everyone. And that concludes this webinar. So that is it. Thank you.